Now we'll move to our last speaker, Dr. Satoy from Kensai Medical University. Thank you very much.
Thanks, Chairman. So I'd like to express my gratitude to Professor Tempela and Professor Okazaki and the scientific committee for giving me an opportunity to talk about a challenging locally advanced and metastatic pancreatic ductal adenocarcinoma in APA and JPS joint meeting this year. A little bit conflict interest here. So you can see the unresectable disease is categorized as unresectable locally advanced disease as well as metastatic disease like liver metastasis and peritoneal metastasis. So recent progress in chemotherapy for ULP provided better survival. The 6 or 8 month using gemcitabine to the 8.5 month to 12 month using recent chemotherapy regimen, even in a metastatic disease, but it is not curative. So we can find higher response rate using recent chemotherapy, ranging from 21% using S1 to 32% using FOLFIRINOX today. So there is no international consensus concerning the role of surgical management of locally advanced disease and the metastatic pancreatic ductal adenocarcinoma. So in this presentation, convergent surgery was defined as an additional surgery during multimodality treatment in patients with the initial ULP, but not planned surgery following neoadjuvant therapy in patients with the resectable disease. So we have conducted mouse center retrospective study, so-called Pancreas 01 study organized by Japanese Society of HPBS. We have collected 58 patients who underwent convergent surgery after favorable response to anti-cancer treatment at least 6 months or longer. So, and also control group was consisted of 101 patients who didn't or couldn't undergo surgical resection even after the favorable response to anti-cancer treatment. The results show this slide. We found favorable prognosis in convergent surgery group relative to control group. The median survival time on convergent surgery group reached at 39.7 months, which is significantly better than 20.8 months in the control group. And also we have conducted subgroup analysis in terms of survival curve according to time from initial treatment to surgical resection. So this slide showed that the patients who underwent convergent surgery at least 8 months or longer had a favorable survival relative to the control group or who patients who underwent convergent surgery between 6 and 8 months after initial treatment. So optimal timing for convergent surgery may be 8 months after initial treatment. So surgical indication of convergent surgery in my institution is relatively strict. Tumor remission downsides to BL or resectable, sometimes still unresectable disease, but negative uptake on PET-CT scan. And decrease tumor marker and maintain performance status at least 8 months for between an initial treatment and a planned surgery. So I'd like to show you our results of 466 patients with unresectable disease from 2006 to 2017. Firstly, ULLA was categorized at 31% and ULM and 69%, but we have introduced routinely staging laparoscopy for radiographically defined ULLA. After the staging laparoscopy, we found 60% of occult distant organ metastasis in radiographically locally advanced disease. So finally, ULLA was recategorized as just only the 13.3% and ULM was 86.5%. And we performed conversion surgery only in 29%, which is a 6% in overall population, which was consisted of ULLA in 22% and ULM in 3.7%, which is relatively, similar to other reports. And the overall survival from initial treatment in conversion surgery is shown in this slide. And median survival time reached 36 months, which was significantly better than partial response and a stable disease or progressive disease. And we performed subgroup analysis in terms of resectability. So you can see there are no significant difference in overall survival between ULLA and ULM. So I think we should not abandon the conversion surgery even in a unresectable metastatic disease. But if patients had a surgical fit. So, but we have to recognize the early recurrence within 6 months after conversion surgery. So this kind of findings may be, conversion surgery may be harmful to the patients because of conversion surgery is consisted of extended surgical resection, which may be resulting in high morbidity and mortality. So we had 6 patients with recurrence within 6 months, which corresponded to the 19% of this study, but we couldn't find any specific surrogate marker using a preoperative factor. So we should find some novel surrogate marker for this kind of finding. So I'd like to summarize the publication in terms of ULLA. Firstly, so a common finding is a wide range of resectability as well as median survival time. So resectability ranging from 20 to 69%, and median survival time ranges from 22 to 40 months or longer. And in terms of ULLA and MAM, it is quite similar findings of wide-ranging resectability. And ULM is a little bit different from the ULLA or ULM. So there are only 5 articles was selected. So resectability is ranging from 2 to 43%, and median survival time is ranging from 22 months to 56 months. So even in a ULM, so conversion surgery can improve the survival, but selection criteria is very important. So I think desirable outcome for conversion surgery should be at least 36 months from initial treatment in ULLA, and at least 24 months from initial treatment in ULM, because in these states FOLFIRINOX can improve the survival. Median survival time reached to the 24 months or more. And also early recurrence rate should be less than 20%, because otherwise the conversion surgery can be harmful to the patients. So, but there is a clinical question: what is an appropriate surgical indications? We found 3 types of surgical indication from the review of the many papers. So one is no progression CT scan, which is an extended surgical indication for conversion surgery. So median resectability was 52%, quite high, but median survival time is only 22 months. And intermediate surgical indication is R0 resection, a clinical response to such as partial response or complete response. Resectability is relatively low, 20 months, but median survival time has increased to the 30 months. And also a very strict criteria in using a clinical response and declined CA19 level. So resectability was very low, only 4.1%, but median survival times was 36 months. So I'd like to propose the algorithm of conversion surgery. So you can, when the patients showed the resectable or border resectable tumor shrinkage from the unresectable disease, it is very easy to make a choice for the conversion surgery. But the patients had showed still unresectable disease on CT imaging. So at this time, we should use the preoperative CA19 levels. Less than 150. And in the patients with a metastatic disease, we have to introduce a staging laparoscopy for excluding the occult distal metastases. So now we are conducting a prospective cohort study of a conversion surgery. We collected 100 patients. So this study will be appeared next year. So next topic is clinical issue of the peritoneal carcinomatosis. So we have conducted the S1 plus intravenous intraperitoneal paclitaxel therapy for patients with peritoneal metastasis. We have conducted a randomized, prospective phase 2 study of this regimen to the patients with peritoneal metastasis. 33 patients was entered. Median survival time reached to the 16.3 months. So finally, surprisingly, we performed conversion surgery in 8 patients, which in median survival time reached to 28 months. So this is a patient about 50 years old. The pancreatic body tumor was of 25 millimeter in diameter, directly invasive to the common hepatic artery, splenic artery, as well as gastroduodenal artery and the celiac trunk. And also a portal vein was fully occluded with yes. And 11 months later, after treatment, the portal vein was a little bit expanded, and a tumor was mostly disappeared on the CT scan. The cytology turned to be negative. Second look staging laparoscopy showed the disappearance of the peritoneal nodules, which was diagnosed peritoneal metastasis in the first look staging laparoscopy. So we have conducted a modified distal pancreatectomy with the celiac access resection with the portal vein resection in assistance of Professor Fuji in the University of Toyama, who is a specialist of an anthrone catheter tube. The pathological findings show T3 and 1M0. Patients were survived 3 years after initial treatment, but she passed away due to the peritoneal dissemination finally. So now we completed March into phase 2 study of gemcitabine plus nab-paclitaxel with intraperitoneal paclitaxel. This study results will be shown in ASCO GI the next year, maybe. And now we are planning randomized phase 3 trial for investigating clinical efficacy of S1 plus intravenous intraperitoneal paclitaxel in comparison with gemcitabine plus nab-paclitaxel. But it was very difficult to collect the funding from the government due to the, this regimen is consisted of generic products. So we challenged the crowdfunding this year for 3 months. Finally, we got the $100,000 from 1,702 ordinary people. So we will start March into randomized phase 3 trial very, very soon. So in conclusion, conversion surgery can improve long-term survival in patients with the unresectable disease, but the early recurrence rate should be more recognized. An appropriate surgical indication for achieving desirable outcome can definitely provide further improved survival and the early recurrence rate. Thank you. Thank you very much indeed for your kind attention.
So obviously, treatment of peritoneal disease with surgery at the end is somewhat controversial. But I have been in conferences recently where there are panels of surgeons that say there is no patient that is not a surgical candidate. What's your view on that? And also in the setting of liver metastasis with primary tumor. Maybe you can tell me your philosophy in that setting as well. Anyone else in the audience doing surgical resection with peritoneal disease? Carlos, you want to comment?
Well, I certainly think it sounds crazy, right, to do surgery for patients with visible peritoneal disease. Having said that, we have encountered patients, as others have, that may have had an initial laparoscopy, biopsy-proven peritoneal disease, that then chemotherapy and appear to be in remission with normalization of the tumor markers, that then we take them with a little bit of reluctance to do an operation, and some of those patients have done well. But we're talking here of a small minority of patients. I think to purposely know there's viable peritoneal disease and to try to resect it or treat it with intraperitoneal chemotherapy, well, we look forward to seeing the data. But nowadays, what is remarkable is patients with pancreatic cancer are living a lot longer, but they're recurring still. And so we're keeping them alive after they recur with all the chemotherapies that we have, FOLFIRINOX or gemabraxine or you name the combination that you want to use. So patients are living longer. So we have to be very careful to say, oh, they live, 28 months. Well, maybe they would have lived 28 months with chemotherapy alone.
Yeah, maybe. Yeah, that's right. I agree with you. So, but basically, so we have a comparative data retrospectively. So before introduction of this new regimen, we had the data of peritoneal metastasis. It's just median survival time. I mean, it's just about 6 to 8 months. So I think this kind of regimen will improve, but we have to compare this regimen with gemcitabine plus nab-paclitaxel or FOLFIRINOX. So otherwise, it is very difficult to solve this issue, I think.
I mean, I will say one thing we haven't heard in the mix of this discussion is does the patient have germline testing, genomic testing? There are clearly different patterns of metastasis, and it might be that if that was incorporated in these studies, we would have a clearer understanding of upfront which patients are going to respond in unique ways and maybe candidates for surgery. So I would encourage us as a community to think about how we can deploy that for this unique set of patients.
Right. And my comment is you have has a success for proceeding the phase 2 trials. And now you are going to the phase 3 trials comparing the paclitaxel IV, IP versus gemcitabine plus nab-paclitaxel. And why don't you use the FOLFIRINOX as a control arm? Because maybe FOLFIRINOX is a more potent chemotherapeutic regimen compared to the
Yes, I think so too. But this phase 3 trial was already planned 5 or 6 years ago, and also at that time, Japanese medical oncologist and a surgeon likes to use gemcitabine plus nab-paclitaxel because of the high toxicity of the FOLFIRINOX. So this is the reason why we choose the nab-paclitaxel as a control group.
Well, thank you, and
Thank you
thanks
very much.
everyone as we continue to learn together how to manage these patients.